Welcome back to another episode of In the Nick of Time with Dr. Hassan. I'm your host, Dr. Hassan. We are joined today by an expert in the neurology field, Dr. Shaheryar Hafeez. Dr. Shaheryar Hafeez is a associate professor of critical care medicine and neurology and a medical director of the neurovascular ICU at UPMC Presbyterian Hospital. His research interests include technology and AI systems in ICU management, medical databases in critical care medicine, and cerebral vasospasm and aneurysmal subarachnoid hemorrhage. Wow. This background gives him a unique perspective on both acute neurological events and broader implications for long-term brain health and dementia. Welcome to the podcast, Dr. Hafeez.
Thanks for having me, Dr. Hassan.
Hey, I'm excited to have you on. Longtime friend. I've asked you millions of questions, so I figured why not give a little bit of access to some of my followers and listeners. Let me start off with one question that I get asked all the time, Dr. Hafeez. A lot of my followers, a lot of the listeners to this podcast are always concerned about dementia and how to prevent dementia as they get older. Do you have, as an ICU critical care neurointensivist, do you have any tips, tricks, things that you should do as you age to prevent any onset of dementia?
Yeah, that's a great question. I think dementia, we have a lot of fear in society about getting dementia, taking care of our loved ones who end up having dementia. Dementia, I always think about as it ends up becoming this diagnosis that there's lots of different kinds of dementia that we talk about. When someone gets cancer, we don't just say, oh, they get general cancer. We kind of get it more specific. And similarly with dementia, there's lots of different kinds of dementia. But there are lots of common threads in the types of dementia and their development that we can do something about. There was a European study that showed that a European study that was longitudinal that followed a group of patients or a group of people for 30 years and kind of looked into all of their habits, whether it was diet and sleep and community and what their risk factors were for the development of dementia. And the real common things that came out of there that we know that can prevent them is exercising, exercising, and exercising. If you exercise roughly 3 times a week, 30 minutes rigorous exercise 3 times a week for, the vast majority of your life, 20, 30 years of your adult life, we know you have a very, very decreased risk of dementia. It doesn't go down to zero, but it's certainly a big decrease. There was a big study looking at the Mediterranean diet that looked at uh, non-processed foods, high amounts of not high amounts, but good amounts of olive oil, and that was shown to decrease the risk of dementia as well. I think that when you think about those modifiable risk factors in your general daily life, that's what we kind of recommend. As an intensivist, someone who works with brain injured patients on a daily basis, there's lots of things that we see in injured patients who, as soon as they get a spontaneous intracranial hemorrhage or a traumatic brain injury, or they develop seizures or a stroke, those patients now are at higher risk for developing dementia. And so there's a lot of things that we can do to hopefully prevent those injuries from occurring. But if you end up having one of those injuries, there's lots of rehab, there's lots of things that we can do that can hopefully decrease your risk of having dementia, but certainly doesn't take it to zero.
So, as somebody who avidly works out for the last 15 years, I've always equated dementia kind of like to fatigue or the brain itself, which is a muscle shrinking. I've always talked about to a lot of my followers and people on social media that it has to do with vasculature and, vasodilation and getting the nutrients, blood, oxygen to your brain. Is there a role in your mind with the vascular perfusion you have to your fingers or to your toes? Does it relate the same way to your brain, the same way people talk about, coronary artery disease and plaques and those kind of things? Is it a similar mechanism when it comes to dementia and or just cognitive decline as you get older?
I think as we look at and examine how the brain functions, the brain and heart are quite connected. We talk about cerebrovascular disease having the similar risk factors as people with coronary artery disease. When you come in for a stroke, we do a very similar evaluation and workup that you would do for a heart attack. And so we modify your risk factors for, uh, screening for diabetes, looking for your lipid profile, screening for sleep apnea, all the same things that would affect your cardiovascular health, we think about with your cerebrovascular health. While the heart is a strong muscle, your brain is, again, it's full of fat. Majority of it is fat. However, there's huge blood vessels there that are supplying your brain. About 20% of your total cardiac output goes to your brain. The brain is only about 2 pounds of your whole body. So you can imagine the amount of blood supply that's going to your brain is so much that the blood vessels there are exquisitely sensitive to damage. One thing that our brain does more than any other organ is something called auto-regulation. When you're doing heavy exercise and the blood pressure in your arms and legs is high, the blood pressure in your brain does not go up in order for you not to, get a brain hemorrhage. Similarly, if your blood pressure is low, the blood vessels in your brain will dilate. That kind of exercise that your blood vessels get from shrinking and increasing their size and getting good blood flow to them, and it goes to the body like that and gets to your brain, it has a tremendous impact on the blood vessels of the brain. And so, yeah, similarly to preventing neuropathy, preventing your gut slowing down, the brain has an incredibly sensitive vascular tone that can be modified by exercise.
It's actually very interesting. There is a social media trend that's going on right now that talks about migraines specifically. It's a hack, a TikTok hack or a Instagram Reels hack, where essentially, if you're experiencing a migraine, you can put your feet in very hot water, and that will take your migraine away. Is that the same type of mechanism that you're talking about here?
Uh, I can't comment specifically on that remedy, but yes, similar things have been tried for migraine that, impact blood flow from the feet, from different parts of your body, and can access, blood flow to your sinuses, blood flow to your neck and head. And when you have increased blood flow to those sections of your body, they can have an effect. One thing we know about migraine is that migraine is a little bit complicated in that there's something called cortical spreading depressions that go on throughout your brain that have a kind of like it's like having an electrical field that is in a negative pattern that's going throughout your brain, and it is impacted by the calcium channels and the blood vessels of the brain. And so there's some new medications out there that can help reduce that negative ion flow and impact the blood vessels in your brain. And some of that does rely on, like I said, blood flow. And while I can't, I don't know if soaking your feet in water has that effect on migraine. There's lots of people have lots of different triggers for migraine, and so I don't discount anything.
I've seen a few of the commentators, a lot of physicians say that it has something to do with vasodilation of your feet, which decreases the total blood in your brain, which then gets rid of the thumping that you feel when you have a migraine. I've never had a migraine, so I don't know myself, but that is what I've been relayed to on social media.
Could help with
Following
some
up with
relaxation. Who knows?
rela so before we go on to the real nitty-gritty questions, I'm gonna put you on the spot. What's your go-to favorite medication for migraine treatment?
Ooh, that's a good question. So I work a lot, I work in the intensive care unit. So for me, I have lots of access to IV medications, and I'll kind of go to them first. When someone comes into the hospital, especially after having a migraine that they cannot shake, they've tried abortive medications at home. We use a lot of triptans that can be given, through the nose or through the mouth. And as a dissolving tablet. They're very great. But once you get to that point and you're coming into the hospital for migraine, we talk about giving migraine cocktails, which is a combination of sometimes two or three medications in combination that can really help with a headache. The first thing I always like to do is I like to give a big dose of magnesium. Intravenous magnesium has a great effect on the brain. It will slow down your heart rate. It will decrease, again, stabilize the membranes and stabilize your neurons. It can really kind of decrease some of these NMDA channels that are hyperactive in your brain. And additionally, I'll give a liter of fluids with that. A lot of people with migraines will be dehydrated when they come into the hospital. Finally, they can be having either diarrhea or vomiting. So a dehydration can certainly set in. So that's helpful. And then I like to, give usually either an antiemetic like Zofran, or and then also with that, either an anti-seizure medication like valproic acid or a steroid. I think a steroid plus magnesium plus some fluid and an antiemetic usually does the trick for most migraines.
That's fantastic, and that's definitely gonna be a TikTok clip because I talk about magnesium all the time, the benefits of magnesium, long-term benefits, short-term benefits, and the help that it gets you to go to sleep a little bit better. For those listening, magnesium does relax your blood vessels, decreases your blood pressure, helps you relax a little bit before you go to sleep as well. But he is talking about the IV infusion of magnesium, which is a little bit different, but also works with the same mechanism. Let's talk about the ICU a little bit, since you are the director of the neurocritical care ICU over at Presbyterian Hospital. And for those listening, that is the biggest hospital in Pittsburgh, the downtown central hub. So anybody who experiences a TBI, stroke, those type of things will be going to Presbyterian Hospital at UPMC and will probably run into Dr. Hafiz there. As someone who works extensively in neurocritical care, you see the brain at its most vulnerable. What are the critical acute neurological events in the ICU that you believe have the most significant yet overlooked long-term implications for cognitive decline and potential dementia development?
Yeah, it's a great question. I think that we are trying to get the word out as much as we can on acute neurovascular diseases, acute traumatic brain injury, and just how crucial those first initial resuscitation, that first 2 to 5 days really is. We know that when the brain gets injured, it kicks off this incredible amount of inflammation that is so detrimental to the brain, but also it has some protective mechanisms. But overall, it's the amount of inflammation that goes on in the brain can rival the inflammation that sepsis can give you. And it happens in a very, very fast manner. The things that can be overlooked that really can impact the brain and its outcome, the patient's outcome, is something as simple as a fever. Early fevers are incredibly detrimental to the brain. We know that sometimes the core body temperature can be 2 degrees less than the brain temperature. So, if your core body temperature is 101, the brain temperature can be 103. And so high fevers will increase your um, metabolic rate of the brain and its processing speed. Additionally, it'll put more stress on the brain. And we know that fever, hypotension, hypoglycemia, seizures, anything that can increase metabolic demand to the brain, as a trauma anesthesiologist, as yourself, you know that CMRO2 can certainly be affected early on in patients, and that autoregulatory cascade is very, very damaged. And it's a dynamic process. So, people who come in, their blood vessels don't work very well. They can't dilate and constrict their blood vessels appropriately. They have all this inflammation going on. They could be a little bit dehydrated, hypotensive, and they could have high fevers, which all impact the brain. We know that keeping the body in as much of a homeostatic state where the body's not under as much stress, we're trying to reduce that stress. It'll reduce the stress to the brain. One thing that we're starting to realize is when we prioritize other organ systems like the lungs or the heart, and we prioritize their kind of perfusion and homeostasis, and we don't prioritize the brain, we know that these patients can sometimes develop cognitive issues later in their life, and we see that sometimes 3 months down the road in something called post ICU syndrome or PIC syndrome. Here at UPMC, at UPMC Mercy, we have a follow up clinic for patients for ICU. One of my colleagues tracks that and has a robust clinic to follow up on some of those patients. We also see patients who have MRI scans after they have been in the ICU, and a lot of them have, structural brain damage just from being in the ICU. They didn't have any stroke. They didn't have any brain hemorrhage, TBI, but their brain looks like they went through something similar to that just from being in the ICU from all that stress. And so, if there's one thing I could share with all the listeners out there is, to recognize the things that can cause the brain to be under more stress and increase the metabolic demand of the brain, like fevers, hypotension, hypoglycemia, especially early on in the resuscitation period.
And I couldn't have said it better myself. The part where you're talking about when your blood vessels don't contract or expand, accordingly to your body's response that's going on to inflammation or sepsis or those kind of things. What he's talking about specifically there is if you have damage to your blood vessels, whether it's a long, prolonged high blood pressure, hypertensive state, or if you have diabetes where the little sugars get attached to your blood vessels and inhibit the ability for them to vasodilate, which is why you typically end up with neuropathy in your feet. You can't feel your feet. You get those sores. It doesn't hurt. It's because the sugars kind of coat the outside or the inside of the blood vessels and they can't dilate. And when they can't dilate, you can't get enough blood to your brain. If you can't get enough blood to your brain, you can't get enough oxygen to your brain. And that starts a domino effect. I'm going to ask you a question that a lot of people probably hope never to be in the position of, but after someone is found down or has a heart attack or has to have CPR in the emergency room, there is this new, not new, but relatively new to anybody who goes to the ER. There's this process where we cool the brain and cool the body. Can you talk a little bit about as to why we do that? What's the reason? What's the thought process behind it?
Yeah, post cardiac arrest care has come a long way in medicine these days. We used to think that if your heart stopped, there's nothing we can do. There's no way you're going to recover. Some of the pioneering work done here at Pittsburgh with our post cardiac arrest service has shown that with good CPR, good resuscitation, we can achieve some really good outcomes. One, it's been out there for quite a while, for several years, is to cool the body down. Cooling the body and inducing hypothermia to either 33 or 36 degrees Celsius has been done in many, many clinical trials. And what we are realizing with cooling the body is the depth of cooling may not need to be as deep. We may not need to go all the way to 33 degrees Celsius, that maintaining at least normothermia, which is not having a fever. So keeping the patient around 37.5 Celsius, and maybe slight hypothermia to 36 degrees Celsius can improve neurological outcomes after having a cardiac arrest. The reason we think that has an effect is because, like I said earlier, temperature just has so much of an effect on the brain and the body. And so if we cool the patients down, it decreases the metabolic demand of the brain while that cardiac arrest is going on. The patient's having this massive catecholamine surge, or they're in this fight or flight response because they're on their deathbed. And as that's going on, and you cool the body down and you cool the brain down, you decrease the amount of blood flow that's needed to go to the brain, giving it some time to recover. When the body, gets recovery, whether that's from pulling the clot out of the heart or stenting or restoring blood flow back to the brain, then we can hopefully, once that blood flow is back to the brain and it hasn't undergone significant damage, then there's a real opportunity for recovery there. I think what's fascinating is in the United States right now, if you have a cardiac arrest, your outcome is really determined by where you live. If you have a cardiac arrest in Pittsburgh, in Boston, and Minnesota, you are much more likely to survive to a good outcome where you can be independent compared to other parts of the country that don't have robust systems established for cardiac arrest, post cardiac arrest care that is established. It's a tragedy. The difference in outcome can be anywhere from 10 to 40%. I mean, it's a huge, huge gap.
Yeah, along those lines, this is a question that I know a lot of you see some ads on TV about stroke symptoms and time is brain. Can you kind of explain that in a easily digestible format for the users or listeners out there? What does that mean when they say time is brain and when these are the stroke symptoms you should look out for and call 911? What are they talking about? What's the risk associated with waiting or seeing if it's just, a common headache or a cold?
Yeah, so good question. So, stroke care, we know stroke care has, again, last 10 years has completely changed the way we do stroke care. If you come into the hospital quickly within 3 to 4 hours of having a stroke, the earlier the better. We can get hopefully those big, large clots out of your brain and get people, so to where they come in with symptoms like weakness on one side of the body, and then we pull the clot out and they're walking out of the hospital the next day. I mean, it is incredible. Time is brain is the axiom we use for as soon as that clot hits your brain, those neurons are at risk, and some of them are imminently dying, minutes at a time. I can't recall off the top of my head how many neurons it is per minute, but it's something in the neighborhood of like 10 to 50,000 neurons per minute. If you're having a stroke, and restoring blood flow to the brain can really impact those neurons. So it is time is brain. The acronym that we talk about in the community is FAST, which are the symptoms that we talk about. So F stands for facial droop, where your face is kind of slooping on one side. A is aphasia, or you're not able to talk very well. S is slurred speech, and so if you're slurring your words, that's something to quickly recognize. And T is, of course, time. And so, getting someone to the emergency room as fast as you can. The stroke symptoms are going to be acute. They're going to happen very quickly. They're going to be usually on one side of the body, not on both sides of the body. And so you're going to see weakness on one side of the body, usually, like I said, with a facial droop, difficulty with speaking. Um, and can be something like, again, it's going to be very quick. You may even see, I usually ask questions like, well, what was, grandma doing at the time when this occurred? And they'll usually say, well, we're having lunch. And then all of a sudden, this happened. And so, getting to the hospital, getting to the emergency room to, get life sustaining treatment is amazing.
Yeah. Speaking of prolific discoveries, have you followed Neuralink at all and Elon's device gadget that essentially helps spinal cord injury victims who are basically quadriplegics able to control things with their mind? What's your opinion on that? Is that the future of spinal cord injury treatment, or is it far fetched?
It's a good question. Sorry, I was just thinking that FAST, the A stands for actually arm weakness, not aphasia. But anyways, just for that clarification. Neuralink is an interesting concept. There's lots of startups, there's other companies who've been trying to bridge the interface between the brain and the spine, and implanting electrodes or implanting different stimulation devices that either go directly on the brain, bypass the spinal cord, that are trying to make these links. Not science fiction. These are definitely things that we do here in Pittsburgh, but also I've seen elsewhere, that when you identify the correct patients that can benefit, you stimulate correctly, you can really get a nice outcome and get people to move their parts of the body that they never could before. I think what we are getting to is the first stages were establishing, can this be done? The second one was, okay, how can we keep someone hooked up to a computer for, with wires for a long time or not? Like, there's some
Yeah.
practical aspects to that. And third, well, now that we know that we can stimulate the brain and get movement in to the muscles, even with brain injuries and some spine injuries, how do we coordinate the muscles and to work in a way that's functional? I think we're getting to that as the next stage. I think what's really cool about rehab care is that we're establishing and we're attacking it on both sides, not
Mhm.
just from implanted electrodes and implanted devices, but also exoskeletons that are incredibly useful devices that can help people go from a little bit of weakness to full on walking. So I think attacking it from both sides, inside and out, is where the future is.
Yeah. It's crazy. I mean, with that and AI, the way AI is progressing, you are touted as an expert in AI and ICU management. Can you tell us what kind of where do you see the future of it? I mean, I know it's still early. AI is barely within in our practice. It's not even existent. I've seen it a few times in surgeon practices and family offices practices, but essentially it's a transcriber that will listen to the entire conversation and filter through and give you the important parts of the conversation, make it into a medical note, prescriptions, that kind of stuff. But it doesn't yet function as a, I guess, AGI, as they say. It doesn't think on its part. Where do you see AI being implemented in the ICU? How do you see it changing not only neuro ICU care, but just ICU care in general? There's so many numbers always in ICU care. There's so much data points for everybody. Where do you see it fitting in? Where do you see it going?
Yeah, it's a good question. I think we're still in the infancy stages of AI and its impact in medicine. There are augmented reality headsets and glasses that our surgeons are using to not only perform surgery, but get data directly to their glasses that impacts their ability to find planes and find different, blood vessels that they couldn't normally see. And it's having a fairly nice impact in that arena. I think as that might translate to the ICU as well, with the practitioner using augmented data to in real time treat their patient at the bedside. I also see the medical record being leveraged with AI software inside it and beyond. I think in a few years from now, we'll be looking at how we check our labs and replace people's, not replace, but treat people's sugar with insulin. Do it right now fairly manually.
Hmm.
That is going to be a thing of the past. We are going to have software that tracks your sugar, that dispenses the insulin, tells the nurse exactly how much to give, or is just going to be hooked up maybe to a pump that does it automatically. I think we're going to have electrolytes that will be taken care of by the AI software, is going to, go directly to the pharmacy, and that those medications, those replacement of people's electrolytes that are changed on a daily basis is something that is going to be a thing of the past as well. So AI is certainly coming to the hospital, to the bedside, and I really think it's up to us clinicians to decide how we want that to be interfaced. Before it's dictated to us, we need to dictate it at the bedside so it helps us augment our care and not replace our care.
It's very interesting you say that. There was a podcast, I think it was Acquired. They did a whole deep dive on Epic, which is basically the medical software that the majority of the top 50 institutions across the country use. They talked about how divided and impossible it is to talk between patient records, even at the different hospitals for the same patient, even if they're both under Epic. Not only that, but if it's Oracle, Cerner, or the other medical records that are out there, they are so convoluted and terrible at what they do. AI being interjected into that, and the ACA, the Obamacare that came out with a bunch of regulations that you have to do and write in your chart for every time you see a patient, whether it's how much time you spent with them, whether it was critical, not critical, all these different check marks to get your billing done, which slows down physician time with their patient. I don't know about you, but for me, we spend probably 80% of our time dictating and 20% of our time actually taking care of patients, and that seems like the easiest, lowest hanging fruit for AI. The interesting part about all of it is that a lot of physicians I talk to, especially when I say, AI is probably going to go for the um, the types of physicians that have a lot of regimented practices, whether it's, they follow protocols for, whatever, pathology slides, radiology, breast mammograms, that kind of stuff. They talk about, a lot of people bring up who's going to be responsible, who's going to be liable if something goes wrong. And in my opinion, and then let me know what you think. In my opinion, I think it's going to become more like insurance companies, or it's more going to become more like the product of Apple or the product of Google, and they will take the liability upon themselves once they perfect their models to a profit and loss ratio that's acceptable, instead of having a physician or somebody on top who's taking the liability of what the AI is doing or not doing, like you said in your example, replacing sodium or potassium or, insulin for sugar management, or even just blood pressure or oxygen flow in the hospital. When it comes to, if your oxygen's going down, the AI could turn up the liters of oxygen going to your nose and the nurse doesn't have to come do it manually. those type of decision making points, in my opinion, are probably going to shift from the liability on those points are going to shift from the physician or the clinician or the practitioner over to those companies, the AI algorithms, whoever comes up with the first, hospital AI algorithm to treat patients, or, the ICU algorithm. Do you see it going that way, or do you see it some sort of collaboration type of thing where you have to kind of manage your AI agents, essentially your AI bots, and they'll give you ideas and then you have to process them and, spit them out? Where do you see it going?
I think when it comes to liability, traditionally, not only just in healthcare but outside of it, person driving the car is the one who's liable and not the software in case there's an accident. If you know in healthcare, the physician is ultimately called the captain of the ship, and
Mhm.
even if there is negligence amongst anyone in the care team, the physician oftentimes is found liable. And so I can just see that the AI software is another arm of the care team, just like the nurses are, the therapists are. And if there's any kind of negligence that goes on or any kind of negative impact, if it's reported to the physician and they know and they're available, they ultimately take most of the responsibility. And if the software is being designed by humans and it is being implemented by humans and it will probably have fail safes involved, then it will become like, will be that way. Now, 10 years from now, 15 years from now, as people get more comfortable and they rely on software tools, maybe that shifts, uh, but it'll probably take a few lawsuits for that to determine that.
I mean, it's an interesting thought experiment. It happens in my brain all the time. What happens if the cars are on autopilot and they drive themselves and they get in an accident? Who's liable? Is it Tesla or is it the driver once they get fully approved for fully autonomy? Where does the liability fall? I mean, is it on the driving software? Is it on the other driver? Is it all, what if both cars are autonomous? Who knows, So as we finish off this podcast, and again, thank you so much for joining us here on the In the Nick of Time podcast. The NFL season is almost right around the corner. Hot button issue has been an issue for the last 5, 10 years. Chronic traumatic encephalopathy, chronic inflammation, athletes doing things that they probably wouldn't do if maybe they weren't, being hit in the head 100 times a week. Where do you fall? Has the NFL done enough to mitigate the risks of CTE? Is it still present? And going forward, would you let your children play football?
As a neurologist and a practitioner in traumatic brain injury, I would not let my own children play contact sports like football or ice hockey until they are probably 17, if not older. I don't, fortunately or unfortunately, I don't have that problem. My kids are not very into sports, which is a tragedy to me. But they either way, yeah. So for me, that's that question answered. Has the NFL done enough? I think the NFL has taken a lot of good steps. There was a lot of, important first steps that were needed to take that they needed to take. And I think they're on their way to continuing that process. I think that they've partnered well with different companies, material scientists, and, to try to establish good helmets and to help with reduction of concussions. There's also a lot of snake oil salesmen out there who are touting all these devices that can
Yeah.
help reduce things, and some of them don't work at all. And so, as a society, we have to be careful for that, but also the NFL and the other major sports leagues. So I think, one of the things that I reminded myself was there's, that new helmet that they're wearing. That's the cover, that goes on the covering. It kind of makes the helmet look really huge. One of the offensive linemen was saying, I got asked a question by one of his other teammates that, "Hey man, like, do you really want to wear that? It's going to make you look stupid." And he goes, "I'd rather look stupid than be stupid." And so I think that once it becomes more accepted amongst the players, they'll probably use them more as well. But there's still a lot of room there. There's all sorts of new materials are always coming out. There's a lot of opportunity there. So I think for material scientists, bioengineers, fluid dynamics, for people who are in those fields, those helmets and mitigation of CTE is certainly a thing that can happen.
Yeah, when they got rid of the kickoff rule, I think that was huge for just the impacts that happened. I have seen in the 15 years I've been watching the NFL, I feel like there has been an appreciable difference in the amount of hard hits. At least there's no more head-to-head contact. Anytime you hit head-to-head, it's an automatic flag. I don't think. I mean, I think some of the old timers think it's a little bit weak when people don't get knocked out on every hit, but appreciably, I think it's still a great game. Still watch it all the time, and I've never been as interested in the game as I am now. So they have taken some steps. There's probably a long way to go, but that's an interesting take. Finally, as we finish up, I ask all the guests, get a lot of questions from 21-year-olds, 23-year-olds about going into medicine, becoming a doctor. What advice do you have? I kind of asked a different question. I asked if you were going to give yourself advice. Now, you've had a little bit of a long journey into becoming a neurocritical care ICU doctor. Back when you were 21, 23, 25-year-old, what advice would you give yourself, knowing what you know now as a physician, as a practicing attending? What advice would you give yourself back when you were 21, 23?
Man, when I was that age and all I could think about, I was laser focused on trying to get into medical school, try to, you know, get the opportunity to be where I am now. And I really never thought I would be here, being as the medical director of a neurovascular ICU at a top 10 institution in the country. So the advice I would give to myself then would be to just keep working hard and keep trying, and don't take no for an answer if that's what your dream really is. Um, and to really keep just obtaining as many skills as you can. I think when you are at that time and you can only think about uh, studying or MCATs and improving your CV, there's so many other skills that you can obtain and that will either pay immediate dividends and may make you pivot, or it might pay dividends down the road. And so I see now that my colleagues who maybe went to public health school or got certifications in Python, or developed their some other side businesses while they were younger, also waiting for school or waiting for their test scores and things like that, they're all just they're all so impactful. And so I would tell anyone, or at least tell myself then, to, not get discouraged, but, diversify yourself and just keep obtaining more and more skills because they can only come in handy later.
That's fantastic. Before we go, Dr. Shaheryar Hafeez, can you tell the listeners and the viewers where they can find you if they're looking for you? Are you a big active guy on Instagram, LinkedIn, TikTok, website? Where can they find you?
They can find me on neuroinsightconsulting.com. That's my website. They can find me on Instagram at shafiz5, and they can also just find me on my University of Pittsburgh website, because I'm old like that.
Got the hair to prove it. Thank you so much for joining us, Dr. Hafeez. And until next time, we love you guys. We'll see you on the next one.
All right, thanks, man. Thanks for having me.
Anytime, brother. Stop.